Okay, week number 7, shoulder. Classifications is the first part. You're going to look at shoulder classifications and broke it down into muscle power deficits. Typically, your tendinitis, bursitis, shoulder mobility, which is more of your mobility problems, adhesive capsulitis, etc. Shoulder movement coordination issues, which is more like instability or AC joint sprain, and shoulder and arm radiating pain, which is like your thoracic outlet or your cervical brachial pain. As we start the exam, we'll go try to do exam by position. First thing in standing, or can be done as well in sitting. You look at cervical scan. You can go through a cervical quadrant testing. Put them in through an extension, side bend, rotate to the same side, overpressure. If they can do that, that's clear. After that, you can start going into observation. Again, look at posture, look at position. And you continue looking at muscle wasting, any kind of spasms, etc. As we continue to work through our exam, you can also work through your posture, your palpation exam. And the key to your palpation exam is that you're going to be very systematic. Remind them to start and do the same thing every time. Maybe start the SC joint, work your way through the clavicle, coracoid, etc. You can go through each component of that. You could read through that component. Next is your active range of motion. So you're going to go through your quick screen for your shoulder girdle motions, Apley's. So they should be able to reach behind their head, elbow back, try to reach their opposite superior angle of the scapula. For Apley's internal rotation, they should be able to touch the opposite inferior angle of the scapula. Same time, they can go through elevation through flexion, and then shoulder girdle abduction. You can also do passive. We're going to do it again in supine. You can do a quick testing, passive elevation through flexion and abduction. In order to help localize it in this position, we can determine is it a local problem, cervical versus shoulder, and then we can go shoulder versus AC, SC. Localization, for example, for this patient, they have pain at 135 degrees of abduction. We have them come just off of that till the pain goes away. Then we add in a cervical component, which will be a quadrant position. If in this position now the pain was gone, but now we put a quadrant position and the pain returned or increased in the arm, it is a cervically driven problem. The next one, once we find out, is this going to be a glenohumeral joint or an SC or AC joint, have them abduct to 135 degrees, have them come back down so the pain goes away. Then we stabilize the shoulder girdle on that same side. Don't let it elevate. If you keep it down and they go up and they have more pain, think glenohumeral. Less pain, think SC-AC. You're not letting the motion go through the SC and AC joint. The exam continues. We're going to do resisted testing. And we could do typical shoulder abduction, flexion. External rotation, we could teach them to do it in two positions. We could do for infra versus teres. Infraspinatus is going to be external rotation at 90 degrees. Teres is external rotation around 45 degrees, in that range. Elbow flexion extension, scapular elevation, which is upper trap elevator, scapular retraction, general test. We can do a thumb up for mid trap or rhomboid. And then we can do protraction, a serratus test, and a pec minor test. And there's videos to see different options for that. And we're going to go through our special testing and go through each component, special test in sitting, so a load shift test. The key to the load shift is make sure that the load the humerus into the glenoid as you translates anterior posterior. That's key. A lot of people just do an anterior posterior shift, but the key is you have to give it a little bit of a load before you translate it. You can do a drop arm test, and the videos will accompany those. A lift off test for subscapularis, a belly press test. Okay, remember a positive belly test press is at the elbow dropping behind the body in extension. We can do sulcus testing, sulcus sign. As we go through, now we'll start to get supine exam. We can do abduction in two parts. We can do glenohumeral abduction with pure, quote unquote, pure external, pure abduction. Don't allow the arm to actually rotate. Kind of grasp it through the elbow and lift it into abduction, and don't let there any external rotation happen. That's pure glenohumeral. Or you can do glenohumeral of the whole, anywhere between 120 and 140 for glenohumeral That's with external rotation. You can do lateral rotation with the elbow at the side and elbow at 90. At the side is more subscap. As you get more to 90, you start thinking more capsular flexion, extension, etc. Supine, you could also do a load shift in that position. You can do a biceps load test. So you can put them abducted to about 120 degrees, externally rotate maximally, elbow flex to 90s, forearm supinated, and resist looking for pain. You do a Kong test, apprehension test, relocation test, surprise test, which is to put the person at that relocation position, maximally externally rotated with posterior directed force applied to the humerus. At the time of range, the examiner suddenly removes the posterior directed force, and you feel for apprehension. You can do a neural as needed, neural tension as needed. We kind of went over that in the cervical part. And we can do passive accessory testing. So options for that, you can do it in any position. One of the options is to do it in seated position. For this position, you can see there's the anterior posterior glide. You can stabilize and move it anterior, stabilize, move it posterior. Again, we can also do this in supine. SC joint, and go over the MOBs for each one. And then what you're going to go over at the end, you're going to go over more of all the special tests like diagnosis. And for that, you can go through and just discuss what we talk about is clusters. So these clusters together, likelihood ratio. This is a good time to talk more about likelihood ratio. Again, the higher towards 10, the better. These are pretty good high. These, except for the subacromial impingement, have pretty good likelihood ratio, positive. As we go through, if you look on the bottom, I put a sign in, I put a little area, and it reminds you what likelihood ratio is. So a lot of these tests were large increases. The only one that was kind of a low increase was the last one, which is 1.7 subacromial impingement.